Thanks so much, Steve, and thanks for the music. As always, excellent choices. Really very excited about this evening. It's a topic that's near and dear to my heart, but one that I kind of think about on a daily basis, and that is a personalized approach to neoadjuvant therapy in rectal cancer. There have been a lot of advances in rectal cancer treatment over the last, I feel like whatever time frame you choose, you have more advances, but it's over the last couple of years even there have been advances. And I think what we really are interested now is, we have all these amazing therapies available in different modalities and different orders, and how do we make sure that we do the right thing for the right patient? So that's really what this evening's topic is all about, and we have an amazing faculty here that I'm going to hand it over with shortly. But really, thanks first to everyone who registered. We have nearly 1,000 healthcare providers that are registered for today's event from over 90 countries all around the world. I can only imagine with the time differences what that is in some of these places. Azerbaijan, wow, that's awesome. So thank you all for joining, and also thanks to all our sponsors, including Cook Medical, Janssen Biotech, Medtronic, and Olympus. So thanks to our sponsors, thanks to our participants, and also thanks to our faculty. Again, world-class faculty here, and people that I work with closely on a regular basis. So besides just knowing these topics very well, it's something that our faculty really deals with on a daily basis, which makes it that much more important. So with no further ado, I want to hand it over to Dr. Krishnamurthy and Dr. Rosen for the further introductions.
Thanks so much, Dr. Liska. We're very excited to have you here and to select us to help lead this panel. We've got a great lineup great lineup ahead, and we're going to want to get right into it. With that, Dr. Krishnamurthy, do you want to briefly introduce everyone, and then we'll get right going into Dr. Miller's presentation, if you want to do that quickly.
Yeah, sure. Thank you, Dr. Rosen. And as Dr. Liska said, we have a stellar faculty lineup here. We have Dr. Hani Chung, who's a staff colorectal surgeon. She's recently joined us from Johns Hopkins. We have Dr. Michael Cruz, who's a staff pathologist and also vice chair for informatics, pathology, and laboratory medicine, and the director of the Center for Pathology Informatics. Dr. Tony Mastroianni, who is staff radiation oncologist. Dr. Jacob Miller, staff radiation oncologist, Dr. Kanika Nair, my colleague in medical oncology, and Dr. Justin Ream, staff diagnostic radiologist. Should be a great evening for all of us. And so, Dr. Miller, you can get us started, please.
It's Miller time.
Wonderful. I'm just going to share my screen. Thank you very much, Dr. Liska, Dr. Rosen, Dr. Krishnamurthy. So again, I'm Jacob Miller, I'm a GI radiation oncologist, and I echo what Dr. Liska said about using a personalized approach for rectal cancer. We have so many different treatment options in 2025, and I'll be discussing the total neoadjuvant therapy approach. I have no disclosures. So the first thing I wanted to talk about is really how do we risk stratify rectal cancers? There's the historical treatment approach where many patients with T3, T4, node-positive tumors all got the same German rectal treatment, but now we have so many different approaches, and it really goes back to risk stratification. So in 2025, we have very well-established data from multiple trials, observational series, and these are the prognosticators that are in our synoptic reports. We know that CEA, distance from the anal verge, deep extramural invasion, T4 tumors, burden of lymph node disease, whether a mesorectal fascia is threatened on the pre-treatment MRI, and presence of extramural vascular invasion really portend a worse prognosis, increased recurrences, but also not all patients have every single one of these risk factors. They don't always correlate with each other, and they're also associated with technical aspects like long-term bowel function, technical difficulty of surgery or radiation therapy, and it helps us really risk stratify individual patients. ESMO in 2017, largely before the total neoadjuvant therapy trials were published, they presented this very thoughtful approach to risk stratification of stage 2 and stage 3 rectal cancers. And you can see each of these prognosticators in different combinations and in different orders, patients are risk stratified into early risk or intermediate risk or locally advanced or advanced risk. And for the treatment approaches that were available at that time, like upfront surgery or short course radiation followed by surgery or long course radiation and TNT, they suggested what I think is a very thoughtful approach for selecting patients for the correct treatment. Some patients with upper rectal tumors with no risk factors can go straight to surgery, whereas patients with involved mesorectal fascia or advanced tumors really should be treated with long course chemoradiation and then in TNT. These guidelines were largely before many of the trials that we'll discuss were published, but more recently, ASCO and ASTRO published their guidelines, and they also risk stratified patients into low, intermediate, or high risk disease. And these guidelines use the same exact prognosticators. So patients in the ASCO guidelines that have low tumors, threatened mesorectal fascia, T4 disease, EMVI, they're considered high risk, and they should really be treated with TNT, starting with initial chemoradiation for maximal downstaging, and then the option of surgery or watch and wait thereafter. Whereas patients with more intermediate risk disease, perhaps they only have T3 disease, a limited burden of lymph nodes without low tumors, those are excellent candidates for the prospect approach to avoid the long-term and short-term toxicities of pelvic radiation. The ASTRO guidelines a little bit more simplified, but any patient with a risk factor is considered for chemoradiation followed by surgery. So in the context of that risk stratification, what are our actual treatment goals and what's the historical treatment approach? Why consider TNT and how do we interpret each of these different clinical trials? So of course, the historical treatment approach for anybody with a stage 2 or 3 rectal cancer was per the German rectal cancer trial. Patients received five weeks of standard long course chemoradiation. 6 weeks later, everybody got total mesorectal excision, and then adjuvant chemotherapy was often planned. But what was observed is that very few patients actually completed the full course of treatment because they were recovering from the side effects of chemoradiation and surgery. Of course, our treatment goals are to cure the patient, but also optimize their quality of life and the burden of the toxicity from the treatments that we deliver. And that involves, in a personalized approach, integrating these individual risk factors, but also assessing what is an individual patient's reproductive function or baseline bowel and bladder function, what's their appetite for organ preservation and the intensive treatment, the surveillance paradigm for that. And what was observed is that there's a lot of limitations for the German rectal approach that move us more towards the TNT era. I think the number one thing is just poor adherence to post-operative chemotherapy. In the TNT trials, adherence to chemotherapy was significantly greater, and the improvement in disease control can largely be attributed to improved adherence to chemotherapy. However, the German rectal approach, 100% of patients had surgery. There was a limited period of time for pelvic downstaging and a longer period of time for ileostomy reversal. So let's move on towards the TNT trials. And I want to cover a few different trials. Perhaps the most important one was the PRODIGE 23 trial. This enrolled patients with T3 or T4 tumors that were below the peritoneal reflection, good performance status and age less than 75. Importantly, 90% of patients had lymph node positive disease, about a third of patients had low rectal tumors, 10% had lateral pelvic lymph nodes, and a quarter of patients had a threatened MRF. Patients were randomized to the standard approach of chemoradiation, surgery, and then adjuvant chemotherapy, or the experimental approach with intensified systemic therapy in the preoperative setting, i.e. 3 months of FOLFIRINOX, followed by consolidated pelvic chemoradiation, surgery, and then adjuvant chemotherapy. And there are a number of different takeaways from this trial. Patients actually in the experimental arm had decreased rates of high-grade neurotoxicity. They had better chemotherapy compliance, and pathologic complete response rates were improved in the control arm from 12% to 28%. Perhaps even more importantly, in long-term follow-up published in 2024, the experimental arm had better overall survival. So this perhaps provides us the strongest evidence that intensification of systemic therapy, better adherence to systemic therapy, decreases disease recurrence and improves long-term outcomes. And that was a statistically significant improvement from 76% to 82%. There are a couple other trials that I'll cover. One is the Rapido trial. This randomized patients to the same control arm of chemoradiation, TME, and adjuvant chemotherapy, or an experimental approach with short course radiation in 5 fractions, followed by consolidation chemotherapy, and then TME. Importantly, they did enroll patients with very locally advanced tumors, including T4, N2, lateral pelvic lymph nodes, or EMVI. And you can appreciate in the top panel here that patients in the experimental arm had a lower rate of disease recurrence or disease-related treatment failure. Importantly, another takeaway from this trial is that in the experimental arm, despite lower rates of recurrence, patients that were treated with short course pelvic radiation seemed to have a higher rate of pelvic recurrence, isolated pelvic recurrence. So more chemotherapy, perhaps lower rates of distant recurrence, but shortening of radiation therapy from long course chemoradiation to short course seemed to be associated with an increased risk of local recurrence in this very advanced population. And then finally, the last trial I wanted to talk about was the OPRA trial. This guides how we treat many of our patients at main campus in Cleveland. And this was a sequencing trial. It wasn't a question of does TNT improve outcomes, but the question is what is the best sequencing of TNT? This is a phase 2 randomized trial. 324 patients were enrolled at 18 US centers. Patients had T3, T4 tumors, node positivity. And patients were randomized to either induction chemotherapy for 16 weeks, followed by consolidative pelvic chemoradiation, and then the option of TME or watch and wait, or upfront chemoradiation, followed by the same consolidation chemotherapy, and then reevaluation. What was observed is that the sequencing of treatment actually didn't impact cure rates. So patients had similar rates of disease-free survival, but what was different is that patients with upfront chemoradiation had a significantly higher rate of organ preservation. So in long-term follow-up, about 55% of patients had long-term TME-free survival. Importantly, there's no role for increasing organ preservation rates with a high-dose boost, and most of the regrowths among patients who elected for organ preservation developed within the first 2 years, and that also provides its information in the surveillance setting. So some of the key takeaways for total neoadjuvant therapy is that we have very well-defined prognosticators that are included in our synoptic report. There's also patient factors that I always assess when I'm meeting a patient for the first time. For example, what is their interest in organ preservation? What's their desire for fertility preservation if they may need or be a candidate for pelvic radiation? We know that compared with adjuvant chemotherapy, total neoadjuvant therapy does decrease recurrence rates and facilitates organ preservation. Short course pelvic radiation, at least in one trial at very advanced tumors, might be associated with an increased risk of pelvic recurrence. And for patients with T3 or T4 tumors, node positivity treated at Cleveland Clinic, many of our patients were treated with upfront chemoradiation followed by consolidation chemotherapy, and then either TME or organ preservation depending upon their response. And that's generally our preferred approach, but there are myriad other reasonable approaches, including the prospect trial and some of the other trials that my colleagues will discuss. I want to thank everybody for your time, and then I'll pass it off to Dr. Nair.
Hi, everybody. Let me just share my slides. All right, good evening. Thanks to the organizers for inviting me. I'm one of the GI medical oncologists, and I'm excited to discuss with you about when we can de-escalate treatment and minimize side effects for our patients without compromising the efficacy of treatment for locally advanced rectal cancer. These are my disclosures. So we'll first discuss MMR proficient rectal cancer and some key trials from that, and then discuss recent updates from MMR deficient rectal cancer. So starting with MMR proficient cancers, the FORWARD trial, this was the first randomized trial to question the role of neoadjuvant radiation versus chemotherapy for locally advanced rectal cancers. It was 495 patients that were randomized in China to one of 3 arms. The first arm was 5-FU with radiation versus FOLFOX with radiation versus FOLFOX alone without radiation. It's important to note that all patients did receive adjuvant therapy, but for the 5-FU and radiation arm, oxaliplatin was omitted with adjuvant treatment, whereas the other 2 arms did receive adjuvant FOLFOX. In the trial, it was for stage 2 and 3 rectal cancer that were within 12 centimeters from the anal verge, and the primary endpoint was 3-year disease-free survival. So as you can see with the patient characteristics, the FORWARD trial included a high-risk population, which is different from the prospect trial that we'll discuss next. Nearly 1/3 of the patients had clinical stage T4 disease, 3/4 were node positive, and 1/3 involved the mesorectal fascia. Half of the patients had low tumors within 5 centimeters from the anal verge, and all of these patients would have been excluded from the prospect trial. Pathological complete response rates were highest for FOLFOX with radiation at 27.5% and lowest at 6.6% without radiation. FOLFOX with radiation also had the greatest downstaging. However, there was no significant difference between the 5 and 10-year disease-free survival, though the 10-year disease-free survival rate for 5-FU and radiation was nearly 10% lower at 10 years. Local recurrence, distant metastasis rates, and the 10-year overall survival were also not significantly different, but the 10-year overall survival again was lower with 5-FU and radiation. Disease-free survival and overall survival correlated to the pathological stage. Downstaging was associated with an increased disease-free and overall survival with impressive hazard ratios of 5.8 and 9.8 for pathological stage 3 disease versus a pathological complete response. For patients who did not have a stoma, anal function was significantly better with the omission of radiation. Patients had less frequent stools as well as less incontinence. Moving on to the PROSPECT trial. So this was a phase 2/3 multi-site randomized trial that evaluated non-inferiority between neoadjuvant chemotherapy with FOLFOX with selective chemoradiation and standard neoadjuvant chemoradiation in patients with rectal cancers that were clinical T2 node positive or clinically T3 and either N0 or node positive. Patients had to be candidates for sphincter-sparing surgery, and patients with clinical T4 disease were excluded, as well as patients who had 4 or more pelvic lymph nodes that were 1 centimeter or greater in short axis and tumors that were within 3 millimeters of the radial margin. And the primary endpoint was disease-free survival. All patients in the all patients in the trial did undergo surgery. There was no non-operative management arm. If patients receiving chemotherapy did not have a 20% response in the primary tumor or receive at least 5 cycles of chemotherapy, they received pelvic chemoradiation. And in this trial, this was 9% of the patients. Looking at the patient characteristics, about 90% of patients had clinical stage T3 disease and 60% of patients were clinically node positive. The median distance from the anal verge was 8 centimeters. So PROSPECT did meet the non-inferiority criterion and showed a 5-year disease-free survival of 80.8% versus 78.6% with chemoradiation. Both arms had similar 5-year overall survival at about 90%, as well as similar local recurrence-free survival at 5 years of 98%. Surgical outcomes were also similar with a similar R0 rate, similar pathological CR rate, though it was slightly higher with the chemoradiation, but that was not statistically significant. And there was also a similar positive margin rate. For patients who received FOLFOX rather than chemoradiation in the neoadjuvant setting, if they did have a positive radial margin or did not have an R0 resection, they did receive chemoradiation in the adjuvant setting, and this was about 1.4% of the population in the study. About 80% of patients in each arm received neoadjuvant therapy, and the median duration of total therapy from randomization to completion of adjuvant therapy was also similar between the arms, between 35 to 37 weeks. Not surprisingly, in terms of side effects, patients undergoing neoadjuvant FOLFOX did have more side effects, such as fatigue and neuropathy. But interestingly, this cohort had less side effects with adjuvant therapy. Patients undergoing chemoradiation had more diarrhea, as well as more neuropathy with adjuvant therapy. And then lastly, looking at the quality of life in the PROSPECT trial, this was similar between both groups, though trends did favor omitting radiation for sexual function, bowel function, and also overall health-related quality of life. Moving on to MMR deficient cancers. So MMR or mismatch repair is a DNA repair pathway essential for maintaining genomic stability during DNA replication and recombination. Deficiency in mismatch repair leads to microsatellite instability and a hypermutator phenotype, and this can occur either sporadically or be hereditary with Lynch syndrome. MMR deficiency is identified in about 5 to 10% of rectal adenocarcinomas, and these patients are less likely to respond to fluoropyrimidine-based chemotherapy. Therefore, universal testing for MMR is recommended in all patients with colorectal cancers. Most people have probably heard of the study of dostarlimab led by Andreas Sursek from Memorial Sloan Kettering. This is an anti-PD-1 agent that's used for the treatment of stages 1 to 3 MMR deficient rectal cancer. Patients received 9 doses of dostarlimab over 6 months. If there was residual disease, patients were then offered chemoradiation. And if there was still residual disease, then patients were offered surgery. If patients had a complete response to dostarlimab, then they were offered non-operative management. The primary endpoints of this study were overall response rate and sustained clinical response at 12 months. Restaging was done with MRI rectum, endoscopy, FDG PET, and also they looked at circulating tumor DNA assessments. So looking at the patient characteristics, and this is updated from the most recent data published in May of 2025, of the 49 patients that have been reported so far, nearly half were clinical stage T3 and about 1/3 were clinical stage T4, and 84% of patients were node positive. And of the 49 patients, there continues to be a 100% complete clinical response rate, which is an amazing thing to see in GI cancer, especially when we're talking about a single agent treatment. Treatment's overall well tolerated with mostly grade 1 and 2 side effects of fatigue, rash, pruritus, hypothyroidism, and diarrhea. There is one patient who was reported to have a grade 3 hypothyroidism. No grade 4 or 5 side effects were reported. The recurrence-free survival is reported at 2 years at 96%. There have been 2 recurrences. One patient had a single high rectal node at 8 months after completion of therapy, and the solitary lymph node was resected. And another patient had a local tumor regrowth at 2 months after completion of treatment, but they declined chemoradiation, which would have been the next step per protocol, and actually restarted anti-PD-1 with a complete clinical response. So far, all patients have been able to maintain organ preservation. The study also looked at a ctDNA assay. This is a new assay that assessed up to 50 tumor-defined mutations in cell-free DNA, and it was highly sensitive with 90% positivity at baseline. This data does include data from the cohort 2 of the study, which includes MMR deficient solid tumors, so it's not just the rectal cancers that are shown here. But ctDNA clearance in all patients who had a complete clinical response was documented by the end of the 6 months of treatment. The time to response for ctDNA was much quicker as opposed to endoscopy, as well as even imaging. So in summary, with the FORWARD trial, we saw similar disease-free and overall survival with neoadjuvant chemotherapy alone, raising concern that maybe we can really drop chemoradiation for patients, but this was a really mixed population. And then also this was performed in a single country, so generalizability to the rest of the world is a question. Pathological downstaging was associated with improved disease-free and overall survival. With PROSPECT, we saw that neoadjuvant FOLFOX with selective chemoradiation was non-inferior to chemoradiation, and patient selection is important. So, but what we don't know is how does it compare to total neoadjuvant therapy that we currently do with induction chemoradiation and consolidation chemotherapy. For MMR deficient cancers, we see durable and complete responses with neoadjuvant immunotherapy with dostarlimab. And so this is the first line for MMR deficient locally advanced rectal cancer. We don't know about reproducibility with other anti-PD-1 agents. And we really need a larger study and longer follow-up, as the data with 49 patients is really encouraging, but still limited. Universal MMR testing is recommended for all colorectal patients. Thank you.
Wonderful, great presentations. We're going to kick it over to our third presenter, Dr. Hani Chung, recently off the free agent market that we acquired here at Cleveland Clinic, and excited for her presentation on stage 1 rectal cancer. And then we're going to get into some fun cases to try to stump our panel. Dr. Chung, you are still muted.
Sorry about that. Can you hear me?
Yes.
Okay, great. All right, thanks for the introduction. I'll be speaking about the treatment of stage 1 rectal cancer tonight. We've been discussing all these approaches and trials, and we're working on the premise that trimodality is the established standard of care. And now we're trying to figure out what we can start to omit from a patient's treatment course to avoid overtreatment, which can affect quality of life, while still maintaining oncologic cure rates. Teasing out the nuances of treatment algorithms is in a multidisciplinary context is critical, not to mention super fun. Sometimes with enough discussion, though, even a straightforward resectable rectal cancer can feel like a conundrum, but it is still standard of care to proceed with surgery first for early stage disease. We sometimes talk about rectal cancer treatment as though having to perform a radical resection is a kind of failure, or that we're unnecessarily committing the patient to poor functional outcomes, when in reality, any treatment of rectal cancer will confer some amount of functional abnormality. The rectal tissue is never the same after radiation. Systemic side effects may be permanent, and resecting the rectum leads to bowel habit changes. So part of the personalization discussion involves figuring out which of these dysfunctions a particular patient is most likely to end up with and would be willing to deal with in order to have acceptable quality of life. So in the treatment of stage 1 and some low-risk stage 2 rectal cancer, upfront surgery is still very much part of the NCCN guidelines. And as a quick overview of the approaches, the radical total mesorectal excision options are LAR and APR. Recently, local excision has gained interest as an alternative to TME after TNT, which I'll discuss later. Historically, though, local excision is reserved for T1 lesions, and that includes transanal excision, TEMS, and TAMIS. Definitive radical operations are offered for T1, T2, and high T3 lesions with low-risk features. This is a nice schematic from a group in Japan showing how surgeons think about rectal tumors. High lesions with ample room below the distal margin allow for low anterior resection. Lower tumors that approach the dentate line but don't invade the sphincter complex can be resected using an intersphincteric dissection and sparing the external sphincters. And then the APR resects the entire sphincter complex for tumors that are involving the muscles. The criteria for local excision are T1 tumors with radiologic evidence that there is no suspicious nodes. Pathology has to be favorable with low-risk features, and very specific growth criteria also exist. Generally, these are the small, non-fixed tumors in just the right location in the rectum. Local excision for these has largely been replaced by advanced endoscopic maneuvers. Approaches to transanal excision involves effacing the anal canal using sutures or a Lone Star device like this on the left. This is great for very low-lying lesions, or using an anoscope to isolate the lesion and using standard instruments. Transanal endoscopic microsurgery utilizes a rigid scope system to insufflate the rectum and long instruments to do the excision. It's probably the platform that has the steepest learning curve, and because of the way the platform is mounted, the position of the tumor and the patient has to be just right. The introduction of a more flexible transanal platform, the gel port, allowed for a way to use laparoscopic and robotic approaches in transanal surgery. And especially with the robotic approach, the precise tumor and patient positioning becomes somewhat moot because of the camera work that's possible. And higher tumors can be treated this way using the air seal system that eliminates the problem of bellowing. These transanal techniques allow for magnified visualization of the tumor, and margins can be accurately marked out before full thickness excision is performed. One thing to be mindful is that in posterior tumors like this one depicted here, a full thickness excision still is buttressed by the mesorectum, but in an anterior lesion, you can end up in the abdominal cavity, prostate, bladder, or vagina. But in reality, it's rare for a surgeon to get a T1 rectal cancer that meet all the criteria for transanal excision, even in high volume centers. Usually the mass has been manipulated or excised endoscopically, but recently there's been interest in expanding the indications for local excision to either replace or precede radical surgery after TNT. The question being, once downstaging occurs, can we get away with locally excising the primary tumor for both diagnostic and therapeutic intent? Sometimes we use local excision as a way to biopsy tumors that have near complete response, but there's increasing interest in using local excision as part of organ preservation. The C6041 trial claimed that local excision after chemoradiation has acceptable recurrence-free survival and that functional outcomes are good. GRECAR2 randomized patients who had a good response to chemoradiation into getting either local excision or TME, and they looked at a composite outcome of death, recurrence, morbidity, and side effects, and found that local excision is not superior to TME. An important takeaway from this study was that about a third of patients underwent completion TME after local excision. After chemoradiation, about 20% of patients were non-responders by imaging. Of the 19 patients who pursued completion TME, 16 had residual cancer on final path. What this tells us is that TNT is exciting, but there will always be a significant portion of patients who just don't respond. And that poses challenges in addressing patient goals both before and during treatment. Even on trial, patients who refused surgery kept refusing surgery, and being given the possibility that they will not need an operation may impact patients' acceptance of surgery when it becomes recommended. The most recent NEO trial omitted radiation altogether and looked at local excision after 3 months of systemic chemo. Organ preservation was achieved in just over half the patients. And one of the drawbacks of local excision following radiation is that there's a very real risk of Lars-type symptoms. So to be able to avoid radiation and keep the rectum pliable for possible local excision is quite attractive. And that's one drawback of these studies, that it's hard to capture the qualitative outcomes of function in an objective way. We'll get into formal case discussions after this, but just as an example of how this plays out in clinical practice, this was a patient with T3 disease who got TNT and had near complete response. There was this bland-looking residual polypoid tissue. Controversially, I biopsied it, which was non-diagnostic, and the MDT team agreed to offer the patient local excision or TME, and the patient opted for local excision. So robotic TAMIS was performed and the path was negative. At 3 months out, there was some granulomatous tissue at the suture line, and biopsies of that were negative. And in my opinion, this is the role for local excision after TNT in those patients whose tumors respond well enough that the tumor essentially meets all the criteria for local excision, but do not meet criteria for complete clinical response. It makes sense to pursue an excisional biopsy for those patients who need more convincing that they need TME. So we discussed that TME is still the standard of care in early stage resectable rectal cancer. The NCCN guidelines do allow for considering TNT for these early cancers, though. Local excision is gaining use in the era of TNT and organ preservation. And TME and local excision after TNT should be performed at high volume centers where outcomes are being scrutinized through accreditation processes. And since currently we're really relying entirely on imaging for staging, I can't emphasize enough the need for experienced radiologists like our own Dr. Reem, who are confident in reading rectal MRIs. There's some evidence that we tend to overstage tumors and patients get overtreated. Interpretation of post-treatment imaging also poses a unique challenge. So there's a need for widespread standardization of that process. We emphasize organ preservation, but the mere avoidance of permanent stoma alone is not necessarily a predictor of high quality of life. A few studies have looked at functional outcomes using survey measures, but there are inherent challenges to interpreting patient-reported outcomes. So for now, personalized treatment involves knowing the data behind trimodality and offering patients the soundest option. And as a part of that, it's good to keep in mind that given a patient's functional and personal goals, that may not always be organ preservation. Thank you very much for your attention.
Amazing. Wonderful talks from our 3 participants here. We're going to get into some cases here. So if you are feeling like me at this point, when you hear Oprah, Prospect, Rapido, Protege, Forward, and you feel like it's alphabet soup with these trials and you can't keep them straight, now we're going to get into, say, a little more clinical application of all these, where we assimilate all these data and how do we individualize all the results to really tailor treatment to the individual patient. I think what you see, the general sense that I think I get and that we see on the day-to-day from all these presentations, is we're starting to realize that although the 3 approaches we have in terms of radiation therapy, chemotherapy, and surgery can all be very effective, they can all have side effects too. And so the question is, how do we maintain an incredible, at best possible oncologic cure or treatment with the least amount of side effects and the least amount of therapy? So all these trials kind of look at how do we take away some of these things and still maintain the excellent overall survival? Because that's the goal, right? Is that we want people to have not only long life, but a long quality of life. So Dr. Krishnamurthy, why don't you kick us off with some of these cases, and we're going to try to stump our panelists and see how they would individualize these care in these cases.
Yeah, thanks, Dr. Rosen. Excellent talks for all the faculty, and you raised, the really important points that it's great having these different options so that we can tailor the treatment to the patient's goals. And so important to think about the toxicities as well as the efficacy. So everyone can see this, I hope. I was worried this would not work properly.
Good.
Okay, great. So our first case, and we'll just quickly go through the background to get the discussion. I would like everybody to participate, anybody who'd like to. And please, you can also put comments in the chat. So this is a young woman, 39 years old, as we are seeing so many young patients with rectal cancer here and around the world. She had 3 months of rectal bleeding and had a colonoscopy for that, thankfully not too delayed. And there was a flat ulcerated mass in the rectum extending from the upper to middle rectal valve about 10 to 15 centimeters from the verge. No metastatic disease on CT scan of chest, abdomen, and pelvis. And she had these studies elsewhere, so I don't have the pictures, but the tumor on flexible sigmoidoscopy was straddling the second rectal valve in the posterior position at 11 centimeters from the anal verge. And there was a small satellite tumor just to the right. This is not biopsied. And then I believe when she came here and had her flexible sigmoidoscopy, that showed these images here, the mass and this little satellite lesion. And I'll let Dr. Ream tell us about her MRI, which I believe was also done at another institution.
Yeah, this was done at an outside institution. So this patient had a mid to upper rectal mass centered along the posterior wall. It was predominantly confined to the wall, but it did look like there was some questionable serosal disruption along that posterior aspect. So based on that, it was read as a T2 or possible early T3. And there were no lymph nodes that met threshold, no EMVI. So T2 versus early T3 and 0.
Thank you. And then the biopsies from that rectal mass revealed moderately differentiated invasive adenocarcinoma. Oh my God, sorry, Dr. Cruz.
No problem. So yes, they did. They did indeed demonstrate invasive adenocarcinoma, mildly differentiated. It was proficient for mismatch repair. Just a quick note, why I don't have the initial biopsy to show now, in keeping with our accreditation standards, all of these cases are reviewed prior to therapy.
Yeah, and keeping with the data Dr. Nair showed us, we really want to see this MMR status on every patient's biopsy. So we have a young woman with a midrectal tumor, MRI suggesting clinical T2 or early T3, node negative, proficient mismatch repair. Ask our panelists about treatment options, like if she were to have surgery, what type of surgery would it involve? And what else should we consider? Maybe
maybe we gotta force people to talk. Tony Mastroianni, you want to radiate everything. You want to radiate this poor little woman, don't you? What do you? It's T2, maybe T3, right?
This is someone that would fit along the lines of prospect, someone that would be reasonable to treat. She's young. We're worried about long-term toxicities in terms of bowels, sexual function, hormonal treatments. It's not unreasonable to consider prospect treating her according to prospect.
Totally
All right, so
agree.
go ahead, please.
I would even challenge that. Does this patient really need chemotherapy? T2, T3 disease. No, T3A at most, probably has a low likelihood of deep extramural invasion. Does she need the short and long-term side effects of chemotherapy as well? Should she go to upfront TME?
And an operation for this with an upper rectal tumor, it would be a low anterior resection, but with an anastomosis that's relatively high up, and so her function would not be terrible, especially if we're able to avoid radiating the area.
Dr. Nair, Dr. Miller has conceded that he doesn't want to give radiation. He's trying to put you out of a job as well and not give chemotherapy. What do you think about that? Is that appropriate in this case, or is he crazy and just trying to take you down with him?
Yeah, I mean, I think you have multiple options here, right? And that's where the patient discussion becomes really important, and what are the patient's goals? So, with it being possibly a T2 and 0, upfront surgery could be reasonable. There is concern maybe an early T3, and so that does, open up for a prospect approach. But if this was somebody who said, I definitely don't want surgery, I mean, I think that's where you would also consider TNT.
All right, so if she were to say, yeah, I've heard all about this LAR stuff that Dr. Liska causes in all of his patients. I really don't want that. How do I avoid surgery? Would you then recommend, well, we could start with chemotherapy? There's a great talk in the chat about some complete responses with, from prospect with chemotherapy alone. Or would you lean towards Oprah with saying, well, TNT has the greatest chance with chemoradiation first as getting a complete response? How would you counsel her in that case?
Yeah, I mean, if this was somebody we were wanting to do non-operative management, I would not feel comfortable with her having only chemotherapy and then doing a non-operative approach. We don't have any data for that setting. And if we're trying to maximize the chances of a non-operative approach, then chemoradiation first would be preferred.
Yeah, I agree with that. I would just say, anecdotally, it's come up where I've had a patient who had prior radiation for prostate cancer, and then, we just give the FOLFOX when we want to do some neoadjuvant therapy before surgery, and the patient had a complete clinical response and refused surgery. So I think there's, there are some cases like that. It's certainly worth studying, but totally agree. Would not feel comfortable with that if our goal is non-operative management. So this patient was, very savvy and really considered all of her options. And she had 2 children. She did not want another pregnancy, but she didn't want toxicities of radiation. But yet she also was hesitant to go straight to surgery. In case this were, truly T3 or could possibly even have some lymph nodes involved. And so actually opted for a prospect approach. So it was great to have that data. And she received 6 cycles of neoadjuvant FOLFOX, which she tolerated pretty well, just some cold sensitivity, fatigue, constipation. And then on her FlexSig, I do have this picture here. After the 3 months, still showing a tumor about 10 centimeters and the 1 centimeter polyp. Not that much change on the FlexSig, but I think next we have our MRI to look at.
Yeah, so in the MR, kind of a similar response. So the tumor has gotten smaller. We're really looking for the post-treatment fibrosis, though, to drive what we call how we score the tumor regression grade. And here there's really only minimal fibrosis, although I would argue that now that questionable T3 is probably no longer present. So I think it looks more like a T1, T2, but based on the kind of minimal fibrosis here, this would be a tumor regression grade of 4, so an incomplete response. And we did not have any nodes that met threshold at this point either.
It's interesting in the prospect, and thank you, Justin. It's interesting the prospect study, the criteria for selective radiation was if there is not at least a 20% reduction in the tumor by, it's quite broad, endoscopy, MRI, or digital rectal exam. And so by length, the tumor had decreased 20% and thickness. But again, that's not part of TRG scoring. But so she actually was reviewed at tumor board and felt to have had enough of a response that she could go on to surgery. And so she had laparoscopic low anterior section. And I'll let Dr. Cruz tell us what was found.
And just to call out the warfighter surgeons, one of the things we always look at for these rectal resection cases are the completion of the mesorectum. And in this case, a great surgical outcome with a complete mesorectum was performed. And next. So we still had a residual tumor. It was invading into the muscularis propria here. We can see the thick bands of muscle with the invading tumor, making this a T2 lesion. Next. Just to kind of bring it all together, so what was left was a 4.1 centimeter mass. It did invade into the muscularis propria. There was lymphovascular and perineural invasion. The margins were negative. All of the lymph nodes were negative. However, there were 2 tumor deposits, which makes this an N1C lesion.
Yeah, that was kind of a surprise. And we just had a presentation at ASCO indicating, tumor deposits having a significant negative predictive impact along the lines of lymph nodes and maybe incorporated in the next staging. And so I was glad that she had received chemotherapy. Of course, then the question is, what did we do now? She had the 3 months of FOLFOX. Should she get any adjuvant chemo, and how much? Dr. Nair, I guess you're my oncologist on the panel.
Yeah, so, we're following the prospect approach, and this patient's continued for adjuvant chemotherapy with another 3 months of FOLFOX. It's, best tolerated. And so I think I would recommend that she continue with the adjuvant chemotherapy, ideally FOLFOX if she can tolerate that. Especially with there being LEI and perineural invasion and those lymph tumor deposits, definitely concerning risk factors. In terms of chemoradiation, as some patients did receive chemoradiation, again, that was for patients who did not have an R0 resection or had a positive margin, so I don't think that would apply here.
Agree, yeah. And so we had a big discussion actually because, I think in rectal cancer, we don't have the data as well as we do for colon with the IDEA trial looking at 3 months versus 6 months. And so, extrapolating a bit on that, she was more inclined to do the 3 months. And so and she was worried about neuropathy. So we negotiated a compromise where she got adjuvant 5-fluoroquinolone for 3 months and doing well. So thanks everyone. Any additional comments on that case? I'm sorry, I can't see the chat, but otherwise we'll move on.
I think one very quick point about this patient population is that as an increasing number of patients are treated per prospect, it's important for not just radiation oncologists, but everybody to know the indications in prospect for adjuvant radiation. This is a patient that if you just look at NCCN and you follow it and you say, oh, they're node positive, we got to do post-op chemoradiation. We know from prospect that those patients can safely avoid post-operative chemoradiation, and this is the patient that would have the most acute and long-term side effects from post-operative chemoradiation. So it's a good outcome from my perspective in terms of avoiding radiation.
Thanks, Dr. Miller. Okay, so
one other comment in these patients with prospect, I think one potential benefit, which we didn't do in this specific patient, would be potentially avoiding a stoma, right? I think it depends on some of the other surgical factors, but what we worry about in patients who got chemoradiation in terms of leaks, it probably does not apply in the same sense to people that only got chemotherapy. So definitely something to think about in these patients, and obviously, especially in a young patient, if you can omit a stoma, that would be a great benefit. Again, it will depend on the height of that anastomosis, which is also a risk factor. Right, if her tumor was at 10 centimeters, that anastomosis is at 5 centimeters, which is relatively low. So again, weighing risk factors there, but something to consider in the prospect patients would be potentially omitting a stoma.
Great point, Dr. Liska. Also have to always remind myself that the anastomosis is going to be a little lower than where the tumor is. So always learning from my colleagues. Moving on to case 2. This is a case of a 76-year-old woman who had developed recent rectal bleeding, and she also had her initial workup elsewhere, so I don't think I have the images, but she had a colonoscopy that revealed what was thought to be an anal mass, 1 to 2 centimeters in size, 1 centimeter from the anal verge, no metastases on staging CT, chest, abdomen, pelvis, but did just note the low rectal mass, it was called. Her biopsy at an outside institution was read as at least intramucosal, moderately differentiated adenocarcinoma. I think we had pictures, Dr. Cruz.
No,
Sorry.
we did not have these,
Okay.
but yes,
Yeah.
we have an in-house biopsy for this.
Okay, and her, we were really glad to see that the tumor had been tested for DNA mismatch repair, and it was missing PMS2. And Dr. Ream, if you could walk us through her MRI, please.
Sure. So on the baseline, she had this low rectal mass that's centered along the posterior wall. There was involvement of the upper internal sphincter and also extension through the wall with abutment of the right levator, although without frank invasion. We had no nodes that met threshold here, so this was a T3B N0 at baseline with a threatened circumferential resection margin.
Thank you. And this is her flexible sigmoidoscopy that showed a malignant tumor in the rectum in the posterior location, 2.5 centimeters from the anal verge, likely invading the sphincter. And this was biopsied. So I think Dr. Cruz would be next.
Yep. So with this biopsy, I have one of the diagnoses that frustrates my fellow colleagues the most, which is where we all think it's invasive, but we don't quite have enough submucosa to call it invasive. So in this case, we would call it at least high-grade dysplasia because of the limited submucosa present for evaluation. But have that discussion and a comment that suggests that this, in the setting of a mass, that this likely represents an invasive process. And next slide. And this is the repeat of the mismatch repair proteins, where we can see that the tumor itself is negative for expression of PMS2. However, it does have retained expression for MLH1 as well as the other partners, MSH2 and MSH6. So there is isolated loss of PMS2 in this tumor.
Thank you. Yeah, that's always a conundrum when it comes up at tumor board that there's no invasive cancer in the specimen, and try to get a second biopsy, but after that, based on the appearance on the imaging, if something's clearly invasive, we often do just go ahead with treatment. And so what treatment should we offer this patient who's got this DMMR T3B N0 tumor with involved mesorectal fascia, low-lying tumor?
So this would be a perfect case for using immunotherapy. The best data that we have is with dostarlimab. So if she can get that, then that would be my preference. And then again, that would be for 6 months with serial evaluations.
Anyone else want to offer anything different? Hard to beat that data. with 100% complete clinical response. So for patients who don't have a contraindication, I think we'd all agree to go ahead. So she did start on dostarlimab, and this was her FlexSig after 3 doses, so 9 weeks into it. She still has this 1 centimeter firm rectal mass, 2 to 3 centimeters from the anal verge, non-circumferential, mostly posterior. And oh, sorry, is this sorry, we'll let Justin go on next for the MRI. I think I had that description on the previous slide.
Yeah. So on the follow-up MR, really not a whole lot of change here. So size is not significantly changed since the baseline MRI. Still looks like it's invading through the wall, abutting the right levator, and involving the internal sphincter as well. So we don't give a tumor regression grade on these because this was immunotherapy and not the standard chemoradiation. But it looks like a incomplete response or non-response based on MR.
So this is after 4 doses of dostarlimab, so 12 weeks into it. So, you know, how's everyone feeling about this? And what should we do? Should we just keep going, or?
Yeah,
You told me 100%, Dr. Nair. You told me 100%, and I'm still seeing something here. What gives?
Yeah, so you know that 100% was at the end of 6 months of treatment. So while patients did have serial evaluations on treatment, we know that we don't expect to see that complete response. You know, the ctDNA response happened much earlier. That median was like around 1.5 months, but then the endoscopic and MRI response actually didn't happen until closer to the 6 months from I think that was about the median. And, you know, I mean, I think it is encouraging that on the endoscopy, there is a slight decrease in the size of the tumor. But I don't think it's surprising that we don't see that response on the MRI.
Dr. Rosen, you can't just read the abstract. You have to read the full text version.
Well, Dr. Liska, that's why I have you as my boss, is to read it for me and tell me what it serves so I can just get the high-level summary.
A lot of that's actually supplemental.
But my question now is what prompted this check at 4 weeks? Is that the standard recommendation, or after 4 cycles, excuse me, is that the standard recommendation of when to check, or do you guys do it based because she was having symptoms and seeing blood? How do you go about with this immunotherapy being such a new treatment regimen? When should we check these people?
Yeah, that's a great question. On the study, patients were checked at 6 weeks, and then at 3 months, and then at 6 months. I mean, you know, in rectal cancer, our standard typically is about 3 months. You know, with TNT, we go to 4 months with the chemotherapy aspect of it. But, you know, I think we don't feel comfortable being blind for 6 months either. But I think just it would be important to not be reactive to what we're seeing as well.
Yeah, great points. And yeah, I had to go back and look at the paper. And, you know, as you said, Dr. Nair, the median time to response was actually 6 months for both endoscopy and MRI. So, you know, I think with this patient, you know, tolerating treatment, not seeing any more blood on the toilet paper, little reduction on the endoscopy would keep going. And so with that, Dr. Rosen, I'll hand it over to you for case 3.
All right, wonderful. I might have to have you click through, Dr. Krishnamurthy, because I think you got you're sharing. So if you could go to the next slide.
Absolutely.
All right, so case 3, we have a 65-year-old male who underwent a colonoscopy for rectal bleeding.
Sorry.
Next. Yeah. Oh, that's right. Yep. So on this colonoscopy, it was found that there was a left-sided / anterior rectal mass extending from the distal rectal valve about 4 centimeters from the anal rectal junction. Next slide. I think we have the pathology here. Dr. Cruz, I don't know if this was on your list to review.
It was. Refreshing.
I'm sorry.
Sorry, a few more slides and then.
Yeah.
Oh, all right. Well, then let's not go to you yet. All right. Well, the next slide. we'll have you the high level summary. My abstract that I'm used to reading only was moderately differentiated adenocarcinoma with a mucinous component, but we'll get back to you in a second, Dr. Cruz. Next slide. There was no evidence of metastatic disease on the CT scans. And next. Dr. Ream, looks like we have you to go over the MRI here for us.
All right. So on the baseline MR, we had this mid-rectal mass along the left anterolateral wall. It looks predominantly mucinous. You can see there's that T2 hyperintense signal within the center of the mass. By MR, it looked like it was completely confined to the wall. It looks like there's an intact serosa, and we saw no nodes that met threshold. So this was a T1, T2, N0 mucinous mid-rectal mass based on MR.
So T1, T2, N0. Can you tell us or talk a little bit about MRI and how you distinguish between T1 and T2, how difficult that is, and how that impacts things? Because obviously that makes a huge difference in some of our treatment plans.
So we don't. So the recommendations are that if T1 versus T2 is going to change management, that should be done with EUS, just because the performance of MR for differentiating T1 and T2 is pretty poor. So typically we just reported if it's confined to the wall as T1/T2. And the major differentiator for us is T1, T2 versus T3.
Dr. Liska, how often are you utilizing EUS in a situation like this? Obviously, we've moved from EUS to MRI for our staging of rectal cancers because less inter-provider variability, right? You have to find someone that's really good at EUS to really distinguish between this T1 and T2. If you're in this situation and that's going to make or break things, do you go with EUS? Do you more go with how it's mobile on exam when you're doing your flex sig? How do you make that determination?
Yeah, I think that's a great point you bring up. Yes, EUS is if you go by the data, is definitely more sensitive than MRI at discerning between T1 and T2. However, with us having really switched over entirely to MRI for our staging, I think the expertise to do that is no longer there, at least not readily available. So I almost never use endorectal ultrasound at this point for T1 to T2. I think I have probably more accurate information by looking at the morphology of the polyp. Like you said, if you can feel it with digital rectal examination, what it feels like, and things of that nature, but definitely have also been proven wrong.
Yeah, I think if we're able to feel it and it's a very mobile lesion, it makes us feel a lot better that it's not deeply attached and more likely to be T1 than T2. Let's go to the next slide. And so now what? So Dr. Chung, we've got this T1, T2 lesion. We know it's got some mucinous type of component, which we know responds more or less favorably to some of our neoadjuvant therapies. What would your next plan be here?
Yeah, especially given the mucinous features, I would be worried about this being locally aggressive. So, I would take into consideration the patient's goals. If they want to do a full thickness biopsy to really prove whether this is T1, T2, and make a decision from there, then I think any of those transanal biopsy options are reasonable. But if this is someone who wants the cancer out, understands that this is an aggressive form of cancer that's not going to respond to the classic TNT sort of approach, then I think of offering a TME is also very reasonable.
Tony and Jacob, if this patient was very much against surgery and really wanted to opt for any type of organ preservation, would you even offer that to them with the mucinous component of this? Or is that so much that you'd say, no way, unlikely to work, and then we're going to set you up for worse surgical outcomes because we radiated you? What are your thoughts there?
We can see if Jacob agrees. Generally, yes, you point out it's mucinous and the signet ring features are bad, but T1 and T2, there's really no indication for doing radiation. I don't have data to support doing that.
Yeah, I agree. I would be hesitant to try for organ preservation in this patient, specifically because of the mucinous features. We know that those patients have lower rates of downstaging with chemoradiation, and they're more difficult to assess. You know, on imaging, they may have a long-term residual mucinous component that can make it difficult to feel comfortable with long-term surveillance. There are certainly low rectal early stage tumors that we do treat with upfront chemoradiation with the goal of organ preservation, even though they don't have advanced tumors or node positivity. Something I often struggle with is committing a patient to true TNT, the consolidation chemo for an early stage rectal cancer, because of course there's toxicities from that. So I would really counsel the patient, especially for this more middle rectal tumor, for a primary surgical approach.
You know, for a couple of radiation oncologists, you really don't like to give radiation to any of these patients. But no, in all seriousness, that I think that highlights the value that I see in having working with such phenomenal, thoughtful colleagues, that we don't just, follow single algorithms. We talk about these cases in multidisciplinary tumor boards and really tailor the individualized approach as we're trying to show here tonight. Next slide. So we took for a transanal minimally invasive surgery, I think one to help us define, to know, is this truly a T1 versus T2 cancer? And the patient was in agreement with that, to not want to jump into a TME or proctectomy if it was not going to be indicated. Next slide. All right, now we've got you, Dr. Cruz.
I wanted to highlight some of the great things from the TAMIS as far as ways that we can handle these types of resections. As it's just really shown here, it's coming out as one piece. We're able to see and identify the mucosal margins as well as the deep margins. So the possibility is, if it's completely out, then we're able to define, where those margins are. And this is just an example of how we will cut those up and submit those into blocks to make slides from. And next. And so, just like we already know, it does have a mucinous component. It actually does break down. You can see a more well-differentiated component breaks down into a mucinous, and then off into a poorly differentiated or signet ring cells. Unfortunately, there was lymphovascular space invasion, so a high risk, as well as it would be considered a positive margin as less than 1 millimeter from the deep resection margin. It was, however, MMR proficient.
All right, next slide. So, all right, so bummer of a result, right? Worst case scenario, we've done a full thickness excisional biopsy here. We have a positive deep margin. It's poorly differentiated. It's T2 on this specimen with a positive margin, so maybe more. There's LVI. It's MMR proficient. It's a left side and an anterior tumor, so less mesorectum buttress, as Dr. Chung taught us in her talk. So now what? It's kind of a bad actor. We don't know for sure it's greater than T2, right? The MRI suggested T1, T2. So do we now, with that positive margin, do a proctectomy? Is there a role for any type of neoadjuvant? There has been sort of some treatment already. Any type of neoadjuvant therapy? Chemoradiation? If we're not sure, do we do short course and immediate surgery like we used to do more often than we're doing nowadays? Dr. Nair, what are your thoughts on what type of treatment we should do next?
With this being a T2 and by MRI it was in 0, I think still recommend TME for this patient.
All right, great. Dr. Miller, Dr. Mastroianni, any radiation now, or still hold the course for now?
I agree with Dr. Nair. I would favor no radiation and going straight to TME. We know that these patients have worse outcomes with the poor diff and signet ring cells, and I would be worried about disease progression during radiation. So I don't see a clear indication for chemoradiation, and I would be reluctant to pursue an organ preservation approach.
Dr. Chung, they want you to operate. You agree with that?
I do. I think adding radiation to the mix here, I don't like, again, with the mucinous tumor, I don't know if it's going to locally respond. And now with the full thickness biopsy that we've done, there's going to be scarring, adding radiation to the mix, and it being an anterior tumor, the patient's likely to end up needing a much wider resection just because you can't tell scar from tumor at the end of treatment. So I think now is probably the best time to move forward with the TME.
All right, next slide. So, someone say something? No. All right, so the care was agreed upon to take for a low anterior section for a proctectomy, and we have the pathology of that. Dr. Cruz, are you doing this one, or is this?
I am. If you can go ahead and jump to the next slide. And so with the resection specimen, there was residual tumor in it. So even though we were less than 1 millimeter from the margin, it does show that still could be a tumor left behind. And here it did actually infiltrate into the pericolonic and perirectal soft tissue. So it makes it a T3 lesion. And unfortunately, when we're looking at the lymph node dissection, we do have positive lymph nodes. And next. So the final, this was a moderately poorly differentiated adenocarcinoma. It was a PT3. It was MMR proficient. It did have metastatic adenocarcinoma to 2 of 30 lymph nodes, so a N1B lesion. And on this final resection, the margins were negative, 2 millimeters from the distal and 15 from the circumferential margin.
All right, so now we've got we've been upstaged. We're a stage 3 rectal cancer. So we got it's a T3N1. The next slide here. And so now what do we do? So it's T3N1 rectal cancer. And Dr. Cruz, maybe I missed it. Relation to the peritoneal reflection, it was below, obviously, right? Or was it straddling?
Yes.
Or okay, below.
Below.
So a distal tumor, a mid to distal tumor, stage 3. Now it's been resected. Now what? Should we do adjuvant chemotherapy? Is there any role for adjuvant chemoradiation with this, fresh anastomosis? Dr. Nair, how would you proceed now? Would you say?
Yeah, I mean, I definitely want them to get chemotherapy, ideally doublet chemotherapy with FOLFOX, given, there's multiple risk factors, poorly differentiated, it's node positive, LBI. I'll let Dr. Miller comment on the chemoradiation.
I personally would not recommend post-operative chemoradiation for this patient. We know that the efficacy of post-op radiation is lower, acute and long-term side effects are higher. Something that I've noted is the NCCN recommendations are relatively crude or sort of one-size-fits-all approach for adjuvant chemoradiation. I really like the ESMO guidelines that break up among patients that don't get preoperative radiation, looking at each of the individual risk factors, and obviously patients with positive margins or tumor deposits that threaten the MRF. Those are patients who can get post-op radiation, but all of the patients simply because of node positivity or T3 disease, in my practice, I don't radiate those patients after surgery.
Great. And Dr. Ream, any thoughts on I think this case highlights that no modality, no imaging test that we have is perfect, right? The MRI didn't see the lymph nodes, and I can tell everyone that's a deficiency, I'd say, in the technology. Dr. Ream is an incredible radiologist who reads these very well. It's not a miss, and we went back and looked at it's not a miss, but how do you sort of consolidate that, I guess?
Yeah, first of all, mucinous tumors are hard for us in general because they're, when we don't have that soft tissue component, it gets really tough for us to, particularly looking for an invasive component. But for nodes, we know all the data is basically that we're at around 70 to 75% sensitivity for nodes because there's just a lot of overlap between normal and abnormal nodes, and we have criteria that we use to preoperatively on the MRI to assign whether or not we have suspicious nodes. And in this case, I went back and reviewed it. I don't see anything that was missed or should have been called preoperatively. I think we just know that we're not great with MRI, or at least not as good as we would like to be. And there are going to be a percentage of cases, 25, 30%, where we may miss nodes on the pre-op MRI.
So I still enjoy being the gold standard.
We bow to you.
That's right.
I
So
will say with
thankfully,
the lymph node itself, it wasn't enlarged, same size as the regular lymph nodes as well. So a little bit, unusual, and that's typical of the mucinous as compared to the more solid tumors.
And so I think you raised a good point, Dr. Cruz, that surgery and pathologic examination is always the gold standard. As we move towards an era where we try to do less and less, we always have to remember, how do we walk that line in terms of providing great oncologic treatment and care, and also not over treating, but also not under treating and not giving people their chance to respond to everything. Thankfully, this patient had a great outcome, had a good surgery with a complete mesorectum and negative margins, and is doing well after adjuvant therapy. This has been an incredible discussion. If we can bring up the wrap-up slides. As we're doing that, I want to thank all my panelists, my faculty, my co-host, Dr. Krishnamurthy. This was really a ton of work for everybody to do, and we all have busy lives, and I really appreciate you guys putting the effort to put this together. And if you haven't already, you can register for the entire Cleveland Clinic series, live from Cleveland Clinic series. The next session will be current treatment and considerations of melanoma on August 13th. Next slide. And thank you very much for joining us from beautiful Cleveland, Ohio. We'll see you guys next time. Thanks again, and everybody have a great night.